So I really liked this video. So I thought that little animated clip told the story as best as anything about cluster headaches. They are often termed the suicide headache, and are devastating, really life-altering in terms of their difficulty to control and their intensity. So if we jump back into our headache algorithm, we see that the criteria for cluster headache are characterized by short-lasting but excruciating intense, just like the little video showed us. Local autonomic symptoms or signs. It has an unmistakable circadian and circannual periodicity, so they tend to suffer daily or nightly attacks over a period of weeks or months, and then it goes away. Yeah, so very tough headache, but if you see your first one, and those will be in, again, a younger patient. You won't be seeing the first one in an older person. If you see something that bad in an older person, you're going to jump out of that algorithm and be thinking of other things. They actually treat them with high flow oxygen, sumatriptan again, the triptans, and other drugs. The key here is bridging treatment with preventive and steroids. Oral steroids may become part of it. They're definitely going to a specialist. You just may be the first one who identifies the problem. So just a quick look at tremors. And again, we often think of Parkinson's disease, which is a chronic illness, when we think of tremors, but there are essential benign tremors. And I'll say that sometimes people are diagnosed with essential tremor or benign tremor, and then later found to be moving towards Parkinsonism. Parkinson's isn't as easy in the early stages to identify as it is later on. But this video just shows you, kind of a typical case of tremor.
NUR is a man in motion.
I come down here and play pool every day.
He's always moving, whether he chooses to or not.
Well, if I don't use it, I go into shaking my right arm real bad, and I can't do anything with it. I can't stop it.
His tremors are a symptom of Parkinson's disease, not to be mistaken for a more common disorder called essential tremor.
Essential tremor is a disorder of the brain. There are some abnormal signals in the brain that miscommunicates with the hands and with the muscles.
Essential tremors are rhythmic shakes, most noticeable when someone is trying to use their fine motor skills.
Tremors can interfere with their ability to write legibly. Other things are getting dressed in the morning, specifically buttoning or zippering or putting on makeup or fastening jewelry. People also have trouble with eating.
On the other hand, Parkinson's patients like Herbert have resting tremors, which come on when they aren't doing anything.
I used to try to stop it, and I'd put it in my pocket, but it doesn't go away.
While tremors link the two conditions, there are several things that set them apart. Parkinson's patients have rigid muscles and a weakness in the face and throat. Eventually, they'll have trouble with walking and balance. Parkinson's stems from a deficiency of dopamine in the brain. Essential tremors is thought to result from faulty neurological impulses. A variety of treatments are available to alleviate essential tremors.
If the tremor is very mild, we usually just prescribe or suggest occupational therapy. If the tremor is a little bit more bothersome, there are a variety of medications, and some of them work very well.
Severe cases may benefit from deep brain stimulation. All options to help people get a grip on their shaking. For Lee Memorial Health System, I'm Amy Osher.
Of a joint that gives resistance to passive flexion, but gives way abruptly to allow easy flexion on exertion of further pressure. This movement resembles that of a clasp knife. A series of catches appears during passive flexion of the extremities. This is called as a cogwheel rigidity. This is a typical feature associated with Parkinson's disease.
So if you want to look at the second video on this slide, it is about Parkinson's, which we really, again, I just want you to be able to differentiate between the two. And the little clip I just showed you was a fake demonstration of knife clasp and cogwheeling that you will see. When I've picked it up before, cogwheeling, I have found it to be a little more subtle, and and it does indicate Parkinsonianism. And usually is unilateral. One more time, location, 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 quickly dancing through the parasthesias. Your exam techniques, you remember back from learning in assessment, things that we kind of skip over a lot of the time. But if a patient is complaining of any sensation of numbness or tingling, whether it be from back pain, going down their legs, or whether it's they've noticed over time, or you have a diabetic, that you are concerned about loss of sensation or any loss of sensation, you really, I think, need to go back to basics in terms of your examination and examine all dermatomes with light touch, which can be a cotton wisp, and sharp touch, which or the use of the monofilament like we use with diabetics to check for sensation. So just to remind us, if you look in your anatomy book or if you look in your assessment book, you want to be sure that you think about the dermatomes of the lower extremity, and there are those in the upper extremity as well, but you want to be sure to examine all the way across and not miss. If you just wipe your cotton swab around the knee, you're going to miss L5 deficit. You're going to miss actually S1 if you're on the inside of the knee only. You might pick up L4, but you really have to kind of be sure you go across the dermatomes and all the way across and down. This cartoon just shows in terms of disc herniation, which is something we'll also be talking about later. When we talk about stocking and glove distribution of parasthesias, as you know from many of you working in clinical settings, this is more common in, this is peripheral neuropathies, and these are common in our patients with diabetes. So the neuropathy or loss of sensation starts distal at the fingertips and toes, and then works its way back up. That is why one of the clinical guideline recommendations for the following of patients with diabetes is to do a monofilament foot exam and look at and check them for sensation at every visit. This is just a kind of interesting one. This is one to put into your little backpack of fun things that you might pick up in clinical and you can be a rock star. There is a peripheral nerve entrapment that can occur at the lateral femoral cutaneous nerve that can cause a numbing sensation in this special place on the side of the thigh, which does not correspond with any of the dermatomes. So it doesn't follow all the way down like a dermatome would down to the foot or to the ankle. And the patient often gives a history of tight clothing, sitting for prolonged periods, and they compress this lateral femoral cutaneous nerve. And it's got a lovely name. It's called neuralgia parasthetica, and that is a beautiful Latin term, but it basically is this paralysis, and people will be quite frightened by it. And it is benign. It has no real pathology. They simply have to stop compressing this nerve, and it will resolve. So that's the end of these slides. Enjoy your time on the discussion board, and keep in touch. Stay safe in the storm. Maybe get out and enjoy a little fresh air later on.